just to equip you with some important terminologies that will stay with you for life as clinicians, especially that because antibiotics or antimicrobials, they represent almost 1/3 of the medications that you prescribe or you deal with in during your clinical career. You're gonna see some names of antimicrobials. Just don't panic with them because most of the names that you're gonna review here today, you're gonna expose to it in the coming lectures. Okay. 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 That's fine. Thank you very much. That's so far. Okay. Okay. So let us start with when we come to naming or definitions of the anti-infective, because sometimes you're gonna look to them as anti-infective agents, and that includes all the agents that we use it to treat bacteria, fungi, virus, and protozoa. So we have the antibacterial, and we have the rest of the antipathogens that we use clinically. So all of them collaboratively, we call them as anti-infective or antimicrobials. Now, the antibacterial, there are substances that specifically are intended to kill the bacteria or stop their multiplications. Then we move to the antibiotics. The antibiotics is the term that not all the antibacterials, they are considered as antibiotics. Now, this is very important to distinguish the two terminologies. Now, the antibiotics, which was discovered initially in the 1910 by Fleming, when he discovered the inhibition of the bacteria in a petri dish, when a fungi, the Penicillium notium, fallen in the petri dish, inhibited the bacteria. That's what we refer to as the antibiotics. The antibiotics, they are agents. It should be initially extracted from a natural source, whether it's plant, fungi, or animal. Now, that's very important that's why it acquired the name bio, the antibiotics, because it's not because they are directed to the bacteria as a biological creature, but it is because the source of these agents is from biological source. And that need to be distinguished fairly from those what we use it today, chemicals that they exert antibacterial effect, like the antiseptics. Now, when we rub our hands with alcohol or phenol or any substance, that exerts a sort of anti-infective and antibacterial agent. But these agents, they are not antibiotics. What we call them antiseptics. Now, we have one of the important antiseptics we use in surgery. We call it the chlorhexidine and iodine, because these agents, these substances, they are not extracted from a biological source. We refer to them as antibacterial or antiseptics. So the two terms need to be clearly distinguished. Now, I believe that MIC, or the minimum inhibitory concentration, I believe you exposed to that during your microbiology sessions, right? You started microbiology, but you got the MICs. Okay, the MIC briefly is a concentration. It describes a concentration of the antibiotic or the antifungi, or sometimes that's mostly their use. It's very rarely used in the antiviral paradigm. It's a concentration that when we place a certain amount of bacteria in a set of tubes filled with a media. So, and each set of tube, like number one, contain a certain level of antibiotic. Tube 2 contain higher, and etc. Till we get level 7, for example, as this illustration shows. Now, the MIC refer to the first tube that show there is no growth. That means that you could see the tube or the media clearly without a cloudy appearance because of the multiplication of the bacteria. So that's what we call it the minimum inhibitory concentration. That means that is the least concentration that we need to suppress the multiplication of the bacteria. It's an important terminology that will stay with you lengthy, because most of the antibiotics, when we use it in hospitals after the culturing the bacteria, we need to define the MIC, especially during these days, because the resistance is exploding in hospitals. Now, let us take this in example. Now, we have the MIC of Streptococcus pneumonia isolated from a mucus aspirate, and they try to figure out which is the MICs for vancomycin and ceftriaxone. So from your understanding, which is the most effective agent or against this strain of Streptococci? Is it vancomycin or ceftriaxone? Vancomycin. What does it mean? That means we need only 0.5 milligram per liter to suppress or to make the tube media clear. So that is only just a touches of the vancomycin, unlike the ceftriaxone. So I hope that this example will just materialize or show you how we could rely on the MIC in clinical practice.
So, Doctor, I have
yes.
a question. Vancomycin, you mean it's a substance that will inhibit the bacterial growth?
True, it's one of the antibiotics. It's one of the important antibiotics that exert activity against gram-positive cocci. Now, when we look to the antibiotics from their mode of activity, how they kill or how they inhibit the bacteria, we have a bactericidal antibiotics. Cidal mean it kills. Okay, so and that's why you're gonna find the cidal and inserted at many names of the antibiotics, by the way, that in field give you a notion that this agent will kill the bacteria. Okay, so especially the trade names. Now we have the bactericidal antibiotics and the bacteriostatic antibiotics. Now the bactericidal, what we mean that the agent that kills the bacteria. In another word, if we're going to define it objectively, that means that after inoculation of a bacteria in a media for 18 to 24 hours at certain conditions, it's a defined condition, by the way, 99.9% of the bacteria will be inhibited on the media. So that clearly define the bactericidal activity. Now, the bacteriostatic, on the other hand, it is the term describe the antibiotic that inhibit the multiplication of the bacteria, which maintain the bacteria at stationary phase. It doesn't multiply. And this type of antibiotics, they require a sort of active and efficient phagocytes to come and engulf the remaining bacteria, which is not multiplying.
So the bactericidal means kills?
Kills, yes. The bactericidal is the agent that kills the bacteria. The bacteriostatic, that's static. It maintains the bacteria in a stationary phase. So these two terminologies, they're widely scattered in the textbooks. You're going to find it in some guidelines. However, do we clinically rely on the bactericidal or bacteriostatic? And always when we select the antimicrobials, the answer is no. Why? Because actually our intention is to clear the bacteria in the hospitals, or even when we deal with the patients outside. Now that's the intention. I'm interested in curing the bacteria, eradicating the bacteria, and achieve cure for the patient. And that both antibiotics actually, in reality, they achieve the goal. So, it's only that we select the bactericidal versus the bacteriostatic in only severe type of infections. And it's not only this, it's severe, because severe and the infection itself has a sort of characteristics that it needs theoretically bactericidal activity. And this type of infections like endocarditis, the problem with endocarditis, because it's a bacteria in the blood, and the bacteria will be surrounded by the fibrin of the mesh formed by the platelets, which act as a foreign body. So we need to clear the bacteria and assure the clearance of the bacteria. The same thing in meningitis. In meningitis, which is the infection of the meninges, the sheath, you're exposed to it you're going to expose it in the, I think after 1.5 months or 6 weeks, where it's an inflammation of this the CSF. Now, the CSF, as you know, it has a low level of WBCs. So theoretically, because as I said, the bacteriostatic agents, we need the bacteria to come and engulf the bacteria that's in the stationary phase, and with the low number of WBCs in the CSF, that will not enable the cure of the infection. So theoretically, on a theoretical basis, we need bactericidal activity in these two types of infections. Now, is it are these two terminologies are absolute? Again, no. Even sometimes when it comes to the bacteria itself. Now, for example, the macrolides that include erythromycin, clarithromycin, and others, they exert a bactericidal activity in vitro against streptococci pyogenes and streptococcus pneumonia. However, we know that these agents actually, they are bacteriostatic. I'm sorry, I just forgot to just elaborate about this table. These groups of antimicrobials, you're going to expose to it in the coming lectures, like the aminoglycosides, and one of them, an example is gentamicin, is this group of antibiotics that are bactericidal. The beta-lactam, 1/3 of the antibiotics prescribed by clinicians will be allocated within the beta-lactams antibiotics. And all the members of this big, large group, they are bactericidal. The fluoroquinolone, that include ciprofloxacillin, they are bactericidal. The glycopeptides like vancomycin, and the lipopeptides like the daptomycin. So these are the most important groups that you're going to be studying during this semester, I believe. The glycylcyclines, including the tigecycline, it's one of the new antibiotics. It's a derivative of the tetracycline. All the tetracyclines, they exert a bacteriostatic activity. The lincosamides, that include clindamycin, the oxazolidine diones like the linezolide, sulfonamides like the sulfamethoxazole, and macrolides that include the clarithromycin. Don't worry, during this lecture, that's not important to memorize the names, but then you're going to expose to each of these groups in the next presentations. Now, the strategies of antimicrobial therapy, we have different strategies, how we define how we are using the antibiotics. First, we have the prophylactic therapy. Prophylactic means that a patient who has no infection, but he is at high risk for infection. So when we give this patient antibiotic, that we are trying or anticipating that the patient might develop infection, so we are trying to prevent the development of infection in this normal, otherwise patient. So that strategy, we call it as a prophylactic. That's what's mostly used pre-operatively before the surgical procedure. Now we have the other terminology called the primitive therapy. That means a patient who symptomatically he look well, but on laboratories, like for example, the patient has elevated WBCs, there's some bacteria in the urine, especially in females, which we call it asymptomatic bacteria. If you started antimicrobial in this type of patients, then that we call it primitive therapy. So the patient clinically has no infection, but laboratory-wise, the patient shows sort of growth of bacteria. The empirical therapy, that means that we are starting an antibiotic in a patient who has an infection, but we don't know which type of bacteria that we're targeting. So we are starting an antibiotic that will cover the vast majority of the probable bacteria in this type of infection. Definitive therapists describe the treatment using antibiotics or anti-infective agents that because include the fungi in a patient who has isolated pathogen, and we know the sensitivity of this pathogen. So we tolerate or we manipulate the therapy to target specifically the isolated pathogen in the media. Suppressive therapy, that's described a strategy of using anti-infective agents in patients that we successfully control the infection, but we are unable to eradicate the infection totally. So these type of patients, they might need a sort of long-term suppressive therapy. For example, patients who undergo splenectomy, removal of the spleen, and you know that what's the importance of the spleen in defending the body, especially against the capsulated bacteria. So those patients, especially in the first 6 months of their life, when we take out the spleen, then the patient will be predisposed to an infection. So we use the suppressive therapy to control or to help the body to fight against the bacteria. Now, this is an example. A patient undergoing a tooth extraction ordered 1 gram of ampicillin to be administered 30 minutes before the procedure. So which type of antimicrobial strategy we are using here? Prophylactic, yes, because the patient is coming to with tooth extraction without a real infection. So we're trying to prevent the descending of the bacteria to the heart. That's our target. It's to prevent the endocarditis. That's what we call it, prophylactic therapy. Good. Now, another pharmacodynamic of antibiotics. I believe you know what's the difference between pharmacodynamic and pharmacokinetics, right? Okay. Now, how the body will react, that's the definition of pharmacodynamics, how the body will react on the medication. Now, we have 2 types of the mood of activity of the, or how the body will react with the antimicrobials. Now, I'm sorry, it's, okay. We have these 2 types describe how the antibiotics exert the activity. Now, we have time-dependent killing. That means, in other words, that as much we maintain the antibiotic above the minimum inhibitory concentration, the MIC that we just elaborated about it just a while ago, as long as the time I maintain the antibiotic above the MIC, I achieve the better killing. So that defines the time-dependent antibiotic. It's not necessary for this type of antimicrobials to achieve high levels in the blood. It's only enough that I maintain it above the MIC for a long time, for the whole day, for example. I'll achieve the best outcomes with the use of these antibiotics. The most important group of antimicrobials that utilize the time-dependent in this pharmacodynamically are the beta-lactams antimicrobials. So we use more frequent doses. So most of these, the beta-lactams, you're gonna find this dose every 4 hours, every 6 hours. The aim of this frequent administration of minor doses is to maintain a good level. It's not necessarily very high, but a good level above the MIC2, so I will achieve the killing of most of the probable bacteria. On the other hand, we have a concentration-dependent antimicrobial. That means that as much I achieve a high level at a certain moment during the day, I will achieve the best outcomes. It's not necessarily that the antibiotic, like how the illustration shows in your right hand, that's as much I achieve during the day, that's from time 0 to 24 hours. Now, as much I achieve a high level, that will eradicate most of the bacteria and will cause a shock for the bacteria. So it will stop multiplying. It's not important for me as a clinician that it will stay lengthy during the day. So we mostly utilize a once daily dose with a high dose. I just achieve this spike, kill most of the bacteria, then I will allow the antimicrobial to descend safely. So those are the two important strategies, which is the time dependent and the concentration dependent. The concentration dependent represented mostly with the aminoglycosides antibiotics that include gentamicin.
So Dr. can you say in the first part that the time dependent one, it's a continuous process, at least that I am above the MIC and I'm killing the bacteria. But the second one, I have to reach a peak level. Then that's okay if I just go.
Let's say, yes, true, yes. Now, sometimes you're going to hear this terminology, narrow spectrum and broad spectrum antibiotics. Now, how do we define the narrow spectrum antibiotics that it doesn't even feel that they are weak antibiotics? Some of them, they are very potent, but their spectrum of activity against the bacteria or the pathogens, the fungi, is only directed to a limited type of bacteria. For example, we have isoniazid. It's only efficient against Mycobacterium tuberculosis that cause the TB. So it has only, but it doesn't exert any activity against other form of bacteria. So we call it a narrow spectrum antibiotic. Though it's very efficient medication, by the way, for TB. Now, we also have nafcillin, which is one of the beta-lactams. It's one of the penicillins. When you see this terminology, S-I-L-L-I-N, that means the antibiotic is a penicillin. Okay, just take it as a rule of thumb, okay, just to help you in memorizing the names of the antimicrobials. Now, the nafcillin is effective against the Staphylococcus species. However, the rest of the bacteria, nafcillin has no real clinical role. So we describe it as a narrow spectrum antibiotic. So it's only against a certain type of bacteria. Now, when we broaden the spectrum for these agents, we call them as a broad spectrum. And that means that one antimicrobial could cover different types of bacteria within the gram-positive and the gram-negative spectrum of the bacteria. Now we have, like, for example, we have meropenem. It's one of the beta-lactams. It's one of the carbapenems. And you have ceftriaxone, which is one of the cephalosporins, which is both of them, they are parts, subclass of the beta-lactams. When you see CE, most probably you are describing a medication from the cephalosporin group. Now, the combination of antibiotics, sometimes we don't rely on using one single solo antimicrobial, or even sometimes we combine it with another inert substance that has exerted a role in the activity, the antibacterial activity. Now, for example, if you know the augmentin, one of the famous antibiotics that I believe many of us in this room use augmentin at a certain time of our life to treat upper respiratory tract infections. We have augmentin consists of amoxicillin, which is a penicillin antibiotic from the beta-lactams. Again, when you see CILL, we are describing a penicillin, plus clavulanic acid. Clavulanic acid is not an antibiotic. It has very minimal antibacterial activity, but we combine the clavulanic acid with amoxicillin to prevent a certain type of beta-lactamases, which are the enzymes released by the bacteria to cleave the active moiety of the penicillins, which is the beta-lactone ring. So by cleaving the beta-lactone ring, the antibiotic will be rendered inactive. So to shield the ring, we administer an agent like clavulanic acid to bind with the enzymes that was released by the bacteria. We call it beta lactamases. Then at the active site, most of the beta lactamases will be bounded or inhibited by this clavulanic acid. So the amoxicillin will exert its activity at the target site, at the cell wall of the bacteria. Some other combinations, like the cilastatin, we combined with imipenem as a dihydropeptidase inhibitor. The dihydropeptidase inhibitor, they inhibit a certain type of enzymes present on the brush border of the renal cells to prevent the rapid excretion of the imipenem. So without the cilastatin, imipenem will be secreted very rapidly, and during its metabolism in the renal brush border, it might form a sort of its toxic outcomes, toxic substance, sorry. So by slowing the destruction or the excretion of the imipenem, that will allow the release slowly of this toxic substance that could be safely secreted from the human body. Other type of combinations, we could combine two antibiotics to achieve what we call it synergistic activity. Synergistic activity, that means referred to when you add like 1 + 1 = 3. So the activity will be added on. It's not like something like 1 + 1 will be 2. That we call it additive therapy. When we know that combining two agents will not give you any more better activity, but it will give you two dual types. When we say synergistic activity, that means when we combine those agents, we get exaggerated activities, not even just as using each agent solely from it comes to the number of bacteria that get eradicated. So one of the advantages of the synergistic activity is shortening the treatment course. For example, when we treat the bacterial endocarditis with ceftriaxone plus gentamicin, it could we only need 2 weeks. On the other hand, when you use ceftriaxone alone, that need 1 month of therapy. Also expand the spectrum coverage, like endocarditis caused by enterococci with a need to be treated with combination of penicillin and gentamicin. The decrease also of the incidence of resistance. Well, that's one of the important aspects of the synergistic activity because we are using two antimicrobials. That's one of the conditions in synergistic treatment. We need to use two antimicrobials from two different groups. We cannot combine, for example, two beta-lactams to achieve synergistic activity. No, we need to use two antimicrobials that exert their activity with two different mechanisms of actions. So meaning that with a different chemical structure, with a different activity, so most probably even the mechanism of the bacterial resistance will be different. So that will confuse the bacteria to build a resistance against two agents that are coming together at the same time, and each one of them is exerting activity with a different mechanism of action. So that will lessen the incidence of developing bacterial resistance. Now, how you select the antibiotics? You have different types of factors: patient's factor, drug factor, site of activity factor, bacterial factor, and we can come to describe each aspect. Now, the selection of the patient factors, you need to look to the patient generally. Most of the antibiotics that are excreted either similar to any other medication. Most of them, they are excreted renally, and some of the antimicrobials, they are excreted hepatically. So you should look to your patient's situation. If the patient is like a patient with liver cirrhosis, you need to avoid those medications or those antibiotics that they are excreted hepatically. And you need to pick up the one that gets secreted renally. On the other hand, patients on hemodialysis, it is better to select an agent that's hepatically eliminated, so you could give the patient a full dose instead of just need to adjust the dose by patient's renal and hepatic dysfunction in patient on hemodialysis. Now, an example of a patient antibiotics that gets excreted hepatically is nafcillin. I tried during this lecture just to try to replicate the name of the antibiotics. I'm going to only just give you one antibiotic that which we know most of the aspects around it. Now, nafcillin, which we described it a while ago as a narrow spectrum antibiotic, it also has an advantage. It's hepatically eliminated. So it's one of the favorite medications in patients with dysfunction. I could give the patient full dose without need to adjust the dose. Now, in patients with renal elimination, renal dysfunction, you should to apply some caution with vancomycin because this medication get excreted renally. Some antibiotics has an advantage of dual excretion, hepatically and renally. So if you have a patient who's renal patient, then the most of the antibiotic will be shifted to be secreted hepatically, and vice versa. If you have a patient who's hepatically eliminated, then most of the antibiotic will be secreted renally. So this is one of the advantages of using ceftriaxone. So you don't need to adjust the dose for any dysfunction in the pathway of elimination of this medication. Age also is a very important aspect when you select the antimicrobial, especially that when it comes to pediatric patient, because pediatric patients, we dose the patient according to the weight. While geriatric patients, elderly patients, we dose them even if you view them as a normal, with their normal creatinine, serum creatinine, in reality, because they are wasting their muscle, the serum creatinine level does not reflect accurately the renal function. Most of the elderly, they are experiencing a sort of decreased renal function, could reach up to 20% of their normal function. But when you look to their creatinine clearance or the serum creatinine, it will be viewed as a normal. So you need to apply some caution in prescribing antimicrobials in elderly patients. I'm sorry, it's like this slide is a repetition of the previous slide. Among the most important agents that we need to apply caution in pediatric patients are the fluoroquinolones. Fluoroquinolones, they're contraindicated in any patient who's aged 18 years or less, because it can affect the joint and can cause exert sort of joint deformities and arthroplasty. Geriatric patients, on the other hand, they also could be suffered by any antibiotics, but one of the famous examples that we drive is the incidence of developing tendinitis with the use of the quinolones in elderly patients. So we need to apply some caution in prescribing these medications in elderly patients. Pregnancy is also a very important aspect when we prescribe antibiotics. Some of the antibiotics, they are teratogenic, and the outcomes of the antibiotics on the fetus will be dependent on the ability of the antimicrobial to pass through the placenta to the fetus. Now, for example, among the contraindicated antimicrobials like the fluoroquinolones, they can cause arthropathy again in the fetus, so they are totally contraindicated. Tetracyclines, especially this illustration shows how it could cause a pigmentation of the tooth and also in the bone. So tetracyclines are contraindicated in during pregnancy. And one of the most famous antibiotic that gets used, especially by females, to manage the frequent UTI called Bactrim or Septra, is a combination of two antibiotics. They can cause congenital malformation, especially when it comes to neural defect. How pregnancy could affect other safe agents that could be used, like the penicillins, which is the answer of this question. All the beta-lactams, they are considerably safe during pregnancy, but it could, because the accumulation of fluid in pregnant females, that will affect the volume of distribution and the whole pharmacokinetic profile of the patients. And some pregnant females shown rapid excretion of activity of the antibiotics. So some pregnant female might need higher doses of antimicrobials. And also by the increasing, the proposed mechanism is that increase in the glomerular filtration rate in pregnant female. Some sort of genetic disorders, like the patient who's experiencing or suffering a sort of glucose 6-phosphate dehydrogenase deficiency. This type of genetic disease is a bit higher in the kingdom here, for example, in the eastern province of the kingdom, and also in the far south part of the kingdom, like in Jizan. It's more prevalent compared to other parts of the kingdom. So you need to apply some caution with patients with the glucose 6-phosphate dehydrogenase deficiency. And also some agents, they could affect the cytochrome enzyme, the P450 cytochrome system, especially the 3A4 like clarithromycin. That will affect the metabolism of other agents. That could be also patient receiving antihypertensive, anti-diabetic agents that could be also secreted by the CYP, and giving just for a short course of antimicrobial could affect the outcomes of these other agents that the patient's using chronically. Hypersensitivity is one of the very important aspects when it comes to antimicrobials because they are antibiotics, because they are biological agents. You suspect that the risk of allergic reaction will be higher compared to any other group of medication. So antibiotics constitute number one in the rank of provoking hypersensitivity reactions in the pharmacological paradigm. You need to describe well how was the allergy. Is it just a sort of skin rash or a type of anaphylactic shock the patient might experience? And so you need to obtain a thorough allergic history from the patient and document this in the chart. You need also to know the cross-reaction between the antibiotics. One of the questions, why we're getting all of the, why I should know which the agents belong to which group of antibiotics. That's very important for the bacterial coverage. And again, to know if there is a cross reaction between the members of one group of antibiotic. So for example, we have a 10% chronicity that a patient who experience a penicillin allergy might develop a cephalosporin allergy. So you might, patient with who develop shock, you need to preclude or contraindicate the use of all the beta-lactam and antibiotics. Now, as I said, most of the allergic reactions come from the penicillins, then followed by the sulfonamides, then the least are the macrolides and the cephalosporins. Now, also the availability, the dosage form of the antibiotic, whether it's IV, intravenously administered, or pyrethrin administered, or oral. Sometimes in severe type of infections, we need to administer intravenous antibiotic because we want to assure that we achieve a rapid and high level to treat a severe type of infection. Now, PO is always the go. That means because sometimes we select an antibiotic in a patient, we assume that the patient will receive 2 or 3 days of antimicrobials in the hospital. Then after that could be switched safely to a good alternative of oral. So that will facilitate the discharge of the patient instead of just staying in the hospital for only receiving parenteral antibiotic. That's what we call the switch therapy. Some adverse effects also play a role in the selecting of the antibacterial. Like if you know a renal patient who's experiencing continuous hyperkalemia, then better to avoid the Septra, the sulfamethoxazole trimethoprim. Some agents might cause also hypokalemia. So if a patient developed already had hypokalemia for any reason, like renal patient or patient who's in a refeeding syndrome, etc., then you need to apply extra caution when starting amphotericin B. Or if a patient who is experiencing at high risk of nephrotoxicity, then maybe not the vancomycin might not be the good or the best choice available. Now, some agents, they might cause QT prolongation in the ECG, similar to any other pharmacological agents. Now, the most probable agent in causing the QT prolongation is the moxifloxacillin, and the agent that's now in the last couple of months we are hearing about it, the hydroxychloroquine. That's used that claimed to be used in COVID. Most of the studies shown that it has no role actually, but instead we're only buying some adverse effect with the use of hydroxychloroquine in COVID patients because of the QT wave prolongation, and that's how patients who receive hydroxychloroquine might die from a cardiac arrest because of the QT wave prolongation. Other adverse effects is the cotrimoxazole use with the angiotensin converting enzyme inhibitors. That's used, famous medications are used in management of hypertension. Costs also play an important role in selection of the antibiotics, to look to the costs of storage, preparation, and the administration. When you give, definitely when you need a medication to be pre-medicated, given with other medications or some precautions that that will turn the antibiotic to be expensive. Or some agents, they need therapeutic drug monitoring. You know what's therapeutic drug monitoring? That's where what we call that TDM, that you need to take a levels and apply some pharmacokinetic module to assure that the patient is receiving the appropriate amount of the antibiotic. Among the agents that frequently undergo TDM in the hospitals, vancomycin and the unmanaged glycosides group. And also patient quality of life. When you select an agent that's giving every 6 hours, while there's have an agent that's given once daily, that means selecting the once daily, that means you're improving the patient quality of life. The site of infections, define the most likely organism at the site of infection. You need to know that was each site of infection is characterized by a certain type of bacterium that's probably seen in this site. For example, if patient has, and that is very helpful by the way in the empirical therapy. When you select an antibiotic for empirical therapy, you need to think about the site and which are the most probable bacteria, and you pick up that antibiotic that's probably covered those bacteria at that site. For example, if you're treating cellulitis, infection of the skin, you need to cover the anti-staphylococcus because most of our skin is full of staph. So hence, you're going to select one of these agents like clindamycin, cephalexin, nafcillin, or vancomycin. Meningitis, you need to target the capsulated bacteria that has equipped by the capsule, enable this bacteria to ascend or to reach the meninges. Otherwise, it's very difficult for bacteria to pass to the CSF. Intra-abdominal infections, because abscesses, because the type of the intra-abdominal infections, they are polymicrobial because you know the GI of humans, it's inhibited by wide spectrum bacteria, anaerobes, aerobes, gram-positive, gram-negatives. You're going to find the whole spectrum sometimes of bacteria in the intra-abdominal infection. So you need to select the antibacterial that cover most of these agents. On the other hand, you need to avoid in pneumonia, for example, the use of daptomycin, because daptomycin is among so it's a very efficient medication, but with a bactericidal activity against the gram-positive. But when it comes to the lung, the surfactant of the alveoli destroy the structure of the daptomycin. So it shouldn't be used in patients with pneumonia. Tigecycline, for unknown reason, there is many theories behind it that it increases the risk of more death in patients who are receiving tigecycline to treat lung infections. So you need to avoid these agents. You need also to determine the dose and the route of administration of the antibacterial to achieve a good dose, and also to enable you to know that if the agent penetrates to the site of infection. Like for the blood-brain barrier, you need like an agent like ceftriaxone that will pass through the to the CSF. The prostate is a very protected organ in human males. It's very only a limited number of antimicrobial could pass through to the prostate, and among those limited solutions we have in our hands are one of the quinolones like ciprofloxacin. The media and the structure of the prostate made it very difficult for antimicrobial, even when achieving very high level in the serum, to penetrate to this gland. The complications also need to consider it, like patients hypersensitive or experiencing allergic reaction. You should not use an agent that might provoke allergy in a patient. Direct toxicity of each group or individual antibiotic. Again, vancomycin is a nephrotoxic or can cause ototoxicity. A manager glycosides also exerts similar adverse effect like the vancomycin. That includes nephro and ototoxicity. Isoniazid that's used to treat tuberculosis can cause neuropathy. And the fluoroquinolones, as we said, it might cause, or its use, their use is associated with developing of tendinitis or tendon rupture. Superinfections, we're coming to that. Superinfection, that means when we treat a patient with antibiotic and eradicating the normal flora that allow different species of pathogens to grow. Because these pathogens, especially in the gastrointestinal tract, for example, they live in competing each other for the available resources. Now, when you eradicate one species, and that allow the other type of species to invade, or sometimes you might acquire the invading species in the from hospitals like the Clostridium difficile, which is among the capsulated bacteria that normally it doesn't infect us. Even if we went to the hospital, I'm working in the hospital every day, but we don't grow C. diff in our GI. But as soon as the patient gets exposed to antibiotics, eradicating the normal inhibitant of the GI, then as this a green light to the C. diff to flourish, to germinate from the capsule and to flourish, and cause what we call it pseudomembranous colitis. And that could be, if it's left untreated or the patient continues the antibiotic, it might turn to toxic megacolon, and that could be a fatal disease. Sometimes candidiasis might flourish also on using of antibiotics. Now, there's different, I believe that you're going to expose to that most, in details in your microbiology sessions. And there's different type of resistance, including the genetic alteration or that lead the bacteria to acquire resistance, like the mutation of the DNA or transfer of DNA in form like in a plasmid to release the beta-lactamase enzymes, or altered expression of protein in drug that's linked to drug resistance, like the modification of the binding site of the antibiotic on the bacteria, so that will not allow the antibiotic to be internalized or to exert its action. Or that will lead to lower the levels of the bacteria, like Pseudomonas, for example. It has the ability to secrete back the antibiotics to the media, so that will lower the antibiotics within the bacteria itself. There's a multi-drug resistance. So we're going to now to talk about the resistance. We have the MDR bacteria. We have the extensively drug resistant and the pun resistant, PDR, XDR, and MDR. How we could distinguish each or describe each bacteria. Now, the MDR means that the bacteria that's get isolated is not susceptible to at least one agent in 3 or more antibacterial groups. One agent in 3 antibacterial groups. So if I have a bacteria that's resistant to 3 antibiotics, that might be described to, but these 3 antibiotics should be from different groups that we have, and then we are describing a multi-drug resistant bacteria. The XDR, that means that the bacteria is resistant to all the available antibiotic groups except two agents in 2 different groups. So we call it as XDR. The PANDR that describe a bacteria that resistant to all the antimicrobial available in our hands. Okay, let's take this as an example. How could the following Pseudomonas aeruginosa could be classified? And that's resistant to ciprofloxacillin, resistant to ceftazidime, sensitive to cefepime, imipenem, resistant again to piperacillin, sensitive to colistin, and resistant to gentamicin. So how you describe? So this is, in your opinion, is the XDR. MDR. So why you selected XDR?
Because the cholesterol is the same as the one before.
No, it's different group. Yeah, so cholesterol is different. I mean, it's a polymyxin, so it's different group. So that would go no blames, because I know that you're not exposed yet to the different type of groups of antibiotics. But generally, I'm trying to materialize the example for you now, because this is most probably, as your colleague just announced here, it's an MDR bacteria, because this bacteria is sensitive to 3 different bacteria in 3 different groups. It's in the cephalosporins, we have cefepime. In the carbapenems, we have imipenem, and in the polymyxins, we have colistin. So 3 groups sensitive, that means we are talking about an MDR bacteria. Okay, thank you very much. And if you have any questions? Okay, thank you very much. If you want to download the lecture, please.